Hi, I'm Dr. Scott Lederhouse. We're going to be speaking about lumbar fusion procedures, the indications, potential risk, complications, and alternatives to such a procedure. We'll go over what your specifics may be in regards to why you may be looking at this video and considering a fusion procedure. For some basic anatomy issues, is comprised of 5 segments for lumbar spine. The numbering is the lumbar 1, 2, 3, 4, 5, with the intervening disc at each level. So you have the disc at each particular level. And when we speak of a disc level, we're speaking of the level above and below the disc, or above and below the vertebral bodies. So for example, this is L5. This is the first part of the sacrum, so we call this disc the L5-S1 disc. This is between the 4 and the 5 levels, so we call this the L4-5 disc, etc. So you get an idea on the counting. This is the back part of the spine, and this is the front of the spine. We do most of our procedures from the back part of the spine, although in selected cases we actually may do an anterior approach to removing a disc and performing a fusion. As far as the general anatomy of the spine bone that we see here, these are the spinous processes. To the side of the spinous process on either side is what's called the lamina. And inside the lamina, where this metal rod goes down, is called the spinal canal. We see that on the sides, on each side, there's a hole where the nerve comes through, and that's called the foramen. The foramen is made partly by the bone above and below, by this structure here called the facet joint. So these are the joints in the spine. When we do a laminectomy, or you may have heard of a laminectomy, that infers removing this whole back section of the spine and opening that up to expose the nerve root sac that goes by there. When we do a laminotomy, or just opening of the spine, that may refer to a small opening within the lamina to get access to the nerve sac. When we do a facetectomy, that talks about removing a complete facet joint. And a foraminotomy would entail removing the opening over top of the nerve root to call what we call a foraminotomy. So these are different terms that may be in the information, and so that you would understand those a little bit better. This is a normal side view image of an MRI scan of the lumbar spine, demonstrating the anterior aspect of the spine, or in front of the spine, each of the discs at each level. This is the spinal canal where the nerves pass up and down. These are the nerves, the little dark areas. This is the end of the spinal cord, ends at about the L1-2 level. And the very white area in here is spinal fluid, which looks just like water. Now these normal discs are white in color, which indicate that there's a normal amount of water content in the disc. As well, the disc height for each one of these discs is normal. So this is a normal MRI scan side view of the lumbar spine. This is a normal lumbar spine view through the facet joints and foramen. This is designated on the left, indicating the left holes are visible. So these are the foramens or holes at each level, and the little dark area inside the hole is a nerve root that exiting through that hole. When we see white around the nerve root, as we see here, that's fat that surrounds the nerve root. And when we see fat that surrounds the nerve root, that indicates that the nerve root is not being compressed in the foramen as it exits the spine. We get similar images looking on the right side as well. This is a normal cross-sectional view of the lumbar spine at the designated L4-5 level. This area in here is the disc, and then we have the spinal canal, which is the canal where the nerves pass. This is the what we call the thecal sac, which contains the spinal fluid, which is this lighter colored area in here, which is all consistent with spinal fluid looking like water. The little dark areas inside that are the nerve roots that float around inside the thecal sac or spinal fluid. This is a normal size spinal canal, normal size thecal sac. Other structures, this dark thing is what we call the ligamentum flavum. That's normal. And then we see normal facet joints on either side. This is the lamina on either side. and the spinous process, the tip of that which you can feel normally with your finger. So this is a normal cross-sectional view of the lumbar spine at the L4-5 level. Now, why would we do a fusion? There may be several reasons to perform a fusion. One might be for what we call mechanical chronic low back pain. Mechanical means that movement produces the back pain. Chronic means that it's been present for more than 6 months. And it would be, ideally when we're talking about performing surgery for back pain, it would be a back pain that's right in the middle of the low back, not off to one side, not up high. It would have to correlate in the area of where you have your pain as far as where we would be performing the operation. Now, sometimes it's easy to determine where mechanical low back pain is coming from, and you'll see some examples of that. There may be one disc level that would be extremely abnormal with a collapsed disc space, and dark discs, which we call discs that have had dehydration or desiccated discs, which again we'll see examples of. Sometimes, however, there may be multi-level degenerative changes in the spine, and it's difficult to determine where the pain may be coming from. In that, it's somewhat of a judgment issue. Other times there can be testing that can be done, which you may have heard of, called a discogram, where needles are placed into the discs individually, and contrast is injected into the disc space, and the pressures are measured. And by reproducing the back pain upon an injection of a particular disc, that may give some information as far as where the painful disc may be coming from. However, discograms are not specific, and you may have an entirely normal-looking disc on an MRI scan that may produce pain. And does that mean that that disc is bad and needs to be fused? And there's a lot of argument back and forth on that. So some physicians will use discograms on everybody, and other physicians don't use discograms on anyone. And so it's up to the discretion of the surgeon which patients or group of patients may need discograms and which ones can be fused simply on the results of an MRI scan. So this is not anything that's written in stone, and it's up to your doctor to determine as the best he or she can which disc level may be responsible for the back pain. Now, other reasons for back pain may be what we call spondylolisthesis, and that's where the actual alignment of the spine is off, where a bone may have migrated one in front of the other, so the alignment is completely off. And there's a grading of the subluxation from what we call a grade 0, which means there's no shift, to a grade 4, which means it's virtually completely slipped off over top of the bone in front, above or below. Most cases are a grade 1 slippage, which means it's between 0 and 25% offset. Now, this can cause back pain. It can also produce compressive radiculopathy. Radiculopathy means the nerves are compressed, which cause a radiating pain, numbness, tingling, and weakness into one or both legs. And so there can be a variety of symptoms that may occur from a subluxation. The subluxation may be on a congenital bony defect called a pars interarticularis defect, which is a defect in the bone that enables the bone to slip forward one over the other, again, which your physician would discuss with you if that's what you have. More commonly, it's a degenerative process where the ligaments weaken out, the facet joints become weakened, and the bone will slip one over the other, causing the back pain and sometimes radiating leg pain as well. Another indication may be for a lumbar interbody fusion is someone who's had a previous discectomy and may have a recurrent disc herniation, or who has gone on to develop back pain. Now, in the patient with a recurrent disc herniation with ongoing leg symptoms, sometimes a redo discectomy can be performed. However, one of the downsides of that is that with multiple operations at the same level, it can reproduce more scar tissue around the nerve roots, which can ultimately lead to chronic pain in the distribution of the nerve root. And patients who have had multiple surgeries at one level can get into chronic pain issues that are sometimes then addicted to pain medications or have pain pumps implanted or other devices to try to control the pain. And so it's been our philosophy that if somebody has had a previous discectomy and comes in either with a recurrent disc herniation and or back pain issues, that we will generally recommend a fusion procedure done on a redo operation to help prevent recurrent issues of chronic pain. Now, the decision on to do a fusion obviously is up to you and the physician. Some patients may not be candidates for a fusion, such as a very obese person with diabetes, in particular if they've had any infection issues, just because the risk of infection in those cases becomes markedly higher. In a patient who doesn't have ongoing infections but may be obese or overweight and have diabetes, your risk at developing an infection from a fusion operation goes much higher than if you weren't overweight and didn't have diabetes. But those are the general indications for a fusion procedure. There may be others, and again, you can speak with your physician about your specific reasoning for doing a fusion procedure. Now, there are many types of lumbar fusions. In the past, fusions were done using what are called pedicle screws, which you'll see examples of shortly, where these screws were put in the back part of the spine into the vertebral bodies and laying down of bone on the back elements. This type of fusion is effective, but it doesn't address fusing the weight-bearing areas of the spine, which are the vertebral bodies. The fusion using just pedicle screws can be effective, but the types of fusions that we're currently doing are what are called lumbar interbody fusions, where the disc material is removed, and in place of where the disc was, we're putting a device that will allow the two bones above and below the disc to actually fuse. The devices that are implanted where the disc used to be are comprised of sometimes titanium implants, occasionally bone implants. Other types, there's plastic material with materials that will form bone as well. Sometimes a patient's own bone, or what are called autograft, which means bone coming from the bone bank to be used in fusion procedures. So there's a variety of different techniques, there's a variety of different implants, and it would be up to your physician to determine which implant and type of fusion would be most appropriate in your case. So we won't address each and every specific one, and for specific questions regarding your particular needs and fusion, you should ask your physician to address those with you. This is primarily meant to be an informative video so that you have a better understanding as far as why we do fusions, under what circumstances, and what the outcomes would be, etc. Devices are used for a fusion procedure. As I mentioned, some of them may be bone, it may be made of titanium, sometimes plastic, so there's a variety of implants, and you'll see examples of these as well. One type of implant that we used to use is a round cylindrical implant. It's made of titanium, and you can see that it has holes in it and a large hole on the end, and this would be inserted into the disc space and packed with patient's own bone, or sometimes allograft bone, and the actual vertebral body would grow through the cage to fuse the vertebral bodies together. We occasionally will do this, although we've changed a little bit in what we're doing, in that we're still doing a lumbar interbody fusion. However, the device that we're using are a little bit different. Currently we're using, and again you'll see other examples of these, little plastic, they're called PEEK, and it's a high density medical plastic, and this is inserted in the disc space, and then it's packed with a material called Infuse, or other materials that are bone morphogenic protein, and these proteins actually form bone better than your own bone would, and so we usually augment the device by implanting this bone morphogenic protein into the device, which forms bone again faster than your own bone. We usually will do some drilling of your own bone away as well in order to gain access into the disc space, and that bone that we drill away will as well go into the disc space and into the implant device, so some of it is actually your own bone. This is a sort of procedure that we're more commonly doing these days, which still involves a lumbar interbody fusion, but also augmenting it with what are called pedicle screws, and these are the pedicle screws on either side. Now, one advantage to this procedure, which we call a TLIF, which means translateral interforaminal fusion. So translateral means off to the side, interforamen means we're approaching it through the foramen itself, and interbody means that it's still removing some of the disc material and causing a fusion between these two bones. The advantage is that we're removing a limited amount of bone. We're removing just a small amount of bone around the facet joint and the lamina, and then we gain access into the disc space, which I think you can a little bit difficulty in seeing. But inside the disc space, after we take the disc out, we have that little plastic implant that we put in there with the infuse, and then packing additional bone inside there. And then we'll often supplement with these pedicle screws. Now, if someone has normal alignment of the spine and not any instability, then sometimes we'll just put the pedicle screws in on one side and not put them in on the other side. If someone has any instability issues, then we'll put the pedicle screws and rods on both sides. Now, what these do is these hold the spine steady during the time that there's going to be a fusion. If all we did is remove the bone here, put the implant in, and didn't put these pedicle screws and rods on, then there would be a much higher chance of further instability and slippage of the spine. So by adding these pedicle screws, it holds the spine still during the time that it fuses. Now, these screws are usually left in position. They don't cause any reaction with the body. It's all made of titanium, and you can have MRI scans through the titanium metal afterwards. It may produce some metal artifact, but patients can still be scanned with these in. But usually they're left in position. There's a lot of muscle that's over top of these, and so you don't feel the screws. However, if for whatever reason there was a need to, they can be removed. But again, ordinarily, if it's just spanning one level, the screws are left into position. These are some of the interbody fusion devices that have been used. Many of them have been titanium. There's one that's bone material in this image. All of these devices are placed within the disc space for the interbody fusion to occur. On the top row are examples of this plastic material that is filled with bone morphogenic protein. On the bottom picture are examples of pedicle screw and rods. This is an example of just the various sizes and shapes that are available for interbody fusion. This is an MRI scan demonstrating a very degenerative disc with what are called modic changes in the bone between the L4-5 level. This is a classic case of a patient that should do well from a lumbar interbody fusion procedure. This is an example of what's called infuse, which is bone morphogenic protein. It's put on this sponge material in a liquid form, and the sponge material acts as a carrier for the infused product to be put into the fusion device. This is an example of a grade 1 offset at the L4-5 level, demonstrating instability of the spine, which is a good candidate for a lumbar interbody fusion procedure. This is that same patient after he underwent a BAK interbody fusion, which is somewhat different than the type of fusion we're speaking about here, but for the same indication. This is a patient who underwent the T-lift procedure with the pedicle screws and rods demonstrated, and 3 little radiopaque white markers within the disc space, which are metallic markers that are placed in the implant for verification of implant position. This is what's called an AP view, or anterior-posterior X-ray of the same patient, demonstrating position of the implant and the pedicle screws being placed on one side in this patient. This is a patient who underwent a BAK interbody fusion at the L4-5 level, demonstrating the white cages at the L4-5 level, and at the level below, the white markers demonstrating the implant with visible bone fusion between the L5-S1 level at the lower level that can be seen. With this fusion device at the L5-S1 level, it's easier to see bone formation than it is through the BAK cages. You will likely have been provided a consent form that would appear on usually just a one-page sheet, and this will go over potential risk complications of the procedure, and we will address this and go over this form shortly in detail. So you can go along with that. This is for information purposes. You will be provided a copy of that form for your review as well, and for your own records. Consent. Your consent may read a little bit differently than this one. However, it'll go over the same issues, and this is something that, again, you can speak with your individual physician regarding any differences that there might be in the wording here. But at least on this one that I have, it's entitled Surgical Risk Complications and Indications for Lumbar Spine Surgery with Fusion Using the Interbody Cage and Pedicle Screw Fixation. First part is skin and soft tissue. It says infection, bleeding, poor healing, scar formation, stiffness of the back. Any operation has potential risk of infection, bleeding, etc. Usually for a 1 or even a 2-level procedure, the amount of blood loss is minimum. We generally don't have to require any transfusion or even suggest that patients donate their own blood or are typed and crossed for a blood transfusion. So the amount of blood loss is generally minimum. Scar formation occurs on everybody as well. A scar forms around the nerves down deeper in the back. That's not anything that anybody can prevent. There used to be some materials that were available for retarding ingrowth of scar. Those are currently not available. There are some materials that can be placed over top of the nerve roots and along the nerve sac that can perhaps retard some ingrowth of scar. But in either case, irregardless of what materials are used, scar tissue will form around the nerve roots, and then of course there will be a scar in the back. Now when we close the wounds, they're closed with dissolvable stitch on the inside, and depending on the length of incision and your skin and how it comes together, sometimes we do what are called subcuticular closure, which means there's no stitches to remove, and we will sometimes supplement that with what's called dermabond, which is a glue material that we place over the wound that holds the wound together well, and it also is a water barrier, so it makes it less likely for bacteria to get in, but as well you can take showers and not have to keep a bandage on the wound. So there are some advantages for using the dermabond, and then the glue material will peel off slowly over a couple of weeks. We'll occasionally bring a small edge of the stitch out one end of the wound or the other to tie a knot on, and that can be trimmed off when we see you back in the office. And the reason we bring that out the end of the skin is because tying a knot right on the edge of the skin can sometimes cause the skin edge to erode, and that's why we bring it out in a separate location. Next part is bone. It says progressive degeneration of the spine. So when we fuse one level, we eliminate the progressive degeneration at that one level, since there's no longer motion at that disc level. However, degenerative changes can occur above and below where we've done the fusion, just as a normal aging process or reaction of the body to stress. So we're not changing any future progression of deterioration of the spine elsewhere in the spine, just at the one level that we're operating on. It says spinal instability, so there would be a low chance of producing instability at the level that we're operating on, and in fact we're doing this operation to try to stabilize the spine. So producing instability at the level that we're operating on would be a very low chance of that occurring. Arthritic bone pain and progressive low back pain, so in many cases we're doing the surgery to try to treat the back pain. In your particular case, if all of your pain is coming from the level that you're having surgery on, then you can expect a good outcome. The amount of pain may be on a percentage basis, perhaps 50% is coming from the level where we operate, and so there still may be some back pain, and we can't make any guarantees that by fusing this it would eliminate your back pain, and you still may have some back pain issues either from arthritis or degenerative changes at other levels in your spine. So we do the best we can to eliminate as much of the pain as possible. However, this is a human effort, and we use our best judgment as far as what needs to be done, and again, this is something that you can speak with your individual doctor regarding the specifics in your case. Failure to fuse. The fusion rate is quite high, and with the use of infuse or bone morphogenic protein, the fusion rate can expect to exceed 90%. In many instances, between 95 and nothing is absolute, so there's no series where there's been 100% fusion, but occasionally approaching that number. Now, things that can retard the fusion would be smoking, and it's not so much the fact of smoking, because they say, well, then I'll stop smoking, but then I'll use nicotine patches. It actually has to do a lot with the blood level of nicotine, which is a vasoconstrictor and actually causes blood vessels to constrict, and as a consequence you may not get proper wound healing. The ingrowth of bone may not occur as well, and so the fusion rate drops off in people who use a lot of nicotine. So it's advisable, if at all possible, to eliminate the nicotine from your habit, and then that will allow the bone to fuse more properly. Infection of the cage or interbody fusion device, possibly requiring removal or possible need to reposition the cage. I can maybe only think of one or two instances where that's occurred. Now, occasionally we'll have patients who will develop infection of the wound, and again, that's more in the patients who are overweight and diabetic. If that is to occur, then the wound is often reopened, and we'll have to irrigate the wound with antibiotic solution. We'll sometimes put in little tubes that'll infuse antibiotic solution inside the wound, and then another set of tubes that eliminates the infuse, and that sometimes goes in for a few days, and then meanwhile patients are often on intravenous antibiotics for up to 8 weeks. This has to be treated aggressively if infections occur, and the infection rate is a low percentage of the patients. Again, the higher risk would be overweight and diabetics. Once we've treated the infection aggressively, then we haven't had to remove any hardware in any patient. If the hardware ever had to be removed and it had not fused, then there might be some major issues regarding the ability to fuse and the alignment of the spine. However, following this up and treating aggressively, that hasn't been an issue, and our group has done well over 1,000 fusion procedures. We started doing these in 1996 when the interbody fusion devices were on the market. So we've done a lot of these. We have a lot of experience in doing these, and we know what to do in the instance of infection, etc. Complete fusion may take 18 months or more. So with the use of the bone morphogenic protein, the fusion occurs more quickly. However, to have a full mature bone, it may take 1.5 years or 2 years of bone ingrowth for that to fully occur. That doesn't mean that you're not able to do any activity during that time, and in fact, in patients that we've operated on, we'll often return them to full work duties, which may even include heavy lifting. For example, we've done a number of series of firemen, and we've returned them all to work without restrictions between 4 and 6 months after an operation like this. Whereas our standard discectomy, you may have to permanently restrict lifting because of a fear of recurrent back injuries, etc. However, once we've fused and this is healed, then this should be as strong as any other level in the back, and you should be able to do most activities. There are, however, other levels in your back, and you need to be aware of that you could potentially injure another level in your back. So it just means you still have to take care in your back, but realize that you've had an operation, but that level of operation should be quite strong. Next section is nerve roots. It says partial or complete injury to one or more of the nerve roots, causing weakness, numbness, pain of one or both legs, possible inability to walk, loss of bowel and bladder control, loss of sexual function. Now, to our use in how we do the spine surgery, we're using microscopes with very bright lights, and we're using small instruments, small little drills, small little bone-biting instruments, and as a consequence, we haven't had any significant nerve injuries with respect to any laceration of any nerves or injury of the nerve sac that goes through the spinal canal. We may touch the nerve root and move it around a little bit, but that's most likely the extent of any kind of nerve manipulation or nerve injury that might occur just from removing the bone. So in our hands, as far as removing the bone, it's as safe as it can be in anybody's hands, and again, we have a lot of experience in doing this. Infection leading to meningitis or abscess, so we've discussed the infection issue and use of long-term antibiotics when there's a foreign body implant, and again, if that were an issue, then that's something that we would have to address aggressively. Development of scar tissue formations around the nerve roots with possible chronic pain in the distribution of the nerve root. We see that more commonly when we do just regular discectomies, because the bone above and below will still move, whereas a nerve root that traverses over a disc may not move because the scar tissue will bind it down to the bone, and as a consequence, as the bone moves, there may be a stretch of the nerve root. But if the bone is fused, then there's no bone movement there, and even though the nerve may be encased in scar and scarred up against the bone, the likelihood of causing any kind of stretch injury at a remote time would be very, very unlikely. So that generally isn't an issue with scar and nerve type pain. Tear in the membrane around the nerves leading to a spinal fluid leak in the back or out the wound. So the sac that contains the nerve roots houses what looks just like water. It's called spinal fluid. And if you get a little nick in the membrane, either from biting off some of the bone or working with the drill, what have you, if there's a little nick in the membrane, we can see where it's leaking. We put a stitch in the membrane and some sealant material over that, and we haven't had anybody who has come back with any type of spinal fluid leakage issue or infection. There would be the rare case of that where the spinal fluid would continue to leak if we didn't see that we had a leak and come out the wound, in which case it would have to have a later repair. However, the likelihood of that happening is very small, since again we're using the operating microscope. Everything is real big and well lit, and we can see exactly where the leak would be. Next section, interbody fusion system. I cannot be guaranteed that the disc level that is fused will change the character or intensity of my low back pain. And again, that comes into where is the back pain coming from. And you'll see some examples where it's real easy to determine where the back pain is coming from. However, in other instances, it's less clear and becomes some judgment issues. So we do our best at trying to determine where the back pain is coming from in each individual patient. And as a result, hopefully that the fusion that's done at the level your surgery is going to be done at, that will cure or significantly improve the back pain problem that you have. The pedicle screws and rods, I understand that the rods and screws may not fully stabilize the spine and supplemental surgery may be necessary. That would be, for example, if there was a breakage of a screw or a rod and we haven't seen that, haven't had to go back in and remove any screws or rods because of that. There's a potential for that, so I won't say always or never, but we haven't had to go back in and remove any screws for breakage prior to the fusion occurring. The rods and screws are occasionally removed after a couple of years if it is felt they may be adding to back pain. So it's what we talked about, but ordinarily they're left in position and the patients don't feel them. We can go in and remove them. It's just another operation to remove them, and we don't feel that that's necessary. Poor screw placement, which may require revision or replacement or removal of a screw. So the screws go through what's called the pedicle, and that's why they get their name pedicle screws. And just below the level of the pedicle, where the screw goes in, is where the nerve root comes out through that hole. We put these screws in under X-ray control, but that doesn't guarantee that a screw may not cause a little bit of breakage of the bone that would touch a nerve root, in which case may cause some radiating leg symptoms. As well, if there was a malpositioned screw, it can also touch up against a nerve root, and if that occurs and we recognize that after the operation, then it may require a second operation to go back in and either remove a screw or replace it into a different position. That's a very rare occurrence, probably less than 1 or 2%, but it's something that we will, on rare events, have to deal with. No guarantee that by adding the rods and screws that there would be a 100% chance of fusion, as again, nobody can say that there's a 100% chance of fusion, but it's well up into the mid-90 percentile. General risk, next section, no improvement or worsening of condition. So your back pain or symptoms may persist. We can't make any absolute guarantees that it won't. Death due to anesthesia or surgery. We've never lost anybody in surgery, haven't lost anybody from an anesthetic death, so these are again potential risks. Allergic reaction to medication. So if you give us your allergy history, we won't give you any medications that you have a specific allergy to. However, you may have an allergy to medications that we would give, and not knowing that you're allergic to that, but we make every effort not to allow that to occur. Risk of AIDS and hepatitis from a blood transfusion, so that's a very low risk of that as well, but again, the likelihood of needing a blood transfusion is very small from this operation, and again, it's probably in the order of 1 or 2%, and it would be more common with multi-level procedures, but in a 1 or 2 level operation, the likelihood of needing a transfusion is close to 0. Prolonged hospitalization for some complications with possible long rehabilitation, particularly in elderly patients who have a hard time getting around. It may require a longer time recovering, and sometimes we'll have patients go to places such as Castle Clean or Rehabilitation Hospital for further rehabilitation and getting strengthening. Other times that can be done as an outpatient with formal physical therapy starting right away. But most of the patients that need more time to recover are elderly patients, as they just need time to get strong and have some assistance in getting up and around. Perforation of the abdominal aorta with bleeding requiring a laparotomy, opening of the abdomen for control of such bleeding. Haven't seen that, but that's the aorta is the main artery from the heart. It runs right in front of the vertebral body. So in theory, if we were taking disc out and we went through the level of the disc with the bone binding instruments or removing the disc material, and we took a piece of the artery out, then that would cause a lot of bleeding. Or if we were putting a screw in too far and got into the artery, then that of course would cause a lot of bleeding. Haven't seen that happen. Again, we're using the fluoroscopic images when we put the screws in, so we're not going beyond the limits of the bone, and we haven't gone beyond the level of the disc and caused any bleeding from the aorta. Again, that's a theoretical risk. The above is not meant to be a complete list of all potential complications or risks, and therefore may not be limited to what has been listed in this outline, such as a non-surgical complication, for example, a heart condition that may come up that nobody knew anything about, or there were no signs or symptoms of, perhaps a lung condition, a pneumonia or emphysema, a urine infection can occur, so any number of non-specific issues can occur as complications in the recovery. However, that's not specific for the operation, and those are generic complications for, again, whatever procedure may be done. Next section is work restrictions. From the time of surgery, we indicate no driving for 30 days or more. That's somewhat relative, and if patients are off prescription medications, because you're not supposed to be driving while you take prescription medications such as painkillers or muscle relaxers because they can make you sleepy, but providing you're off those medications at least during the day, and that you're not getting any spasms or cramps in the legs or in the back, and that you have good control and use of your legs, you should be able to drive. And that might be a week in somebody, it might be 2 weeks in another person, it might be a month or more in another person, again depending on their recovery and function level. So the no driving period is somewhat relative, and you can speak with your physician specifically about that when we might feel that you'd be able and ready to drive. No bending, lifting, twisting, no housework, no yard work, limited initiative walking and resting. So when patients first go home, we encourage them to do as much walking as they feel comfortable doing. There's really no limit to the amount of walking you can do. As far as housework and that type of thing, it's a good idea to speak with us before you engage in a lot of bending and lifting, and we generally suggest that patients not bend at their waist, because even in normal backs it can stress the back out and cause disc herniation and other problems of the back. So speak with us regarding your specific activity. Once patients come back in the office for a post-operative visit, we'll often give exercises to you to start performing in addition to doing your walking. And in most instances with fusion procedures, we'll suggest some form of physical therapy for a month or so, depending on your recovery and all. If you happen to be a work comp case, then you may need some work hardening prior to going back to work, or even if you do heavier work, you may need some work hardening prior to doing that heavy lifting, etc., prior to going back to that type of work again. Off employment for 2 weeks to 3 months or more, depending on your job. Again, it would, if you're doing a desk type job, it would be whenever you feel comfortable to return to work. There's no specifics on the date of return. It just depending if you feel comfortable able to sit and do your job. If you have more physical work to do, a more demanding job physically, then again you would need to speak with us regarding some specifics on how long we feel you may need to be off work. If heavy lifting is required for your job, then you may have a permanent disability from performing such work. Again, you speak with us regarding your activity. Progressive activity will also be directed by your physician in the postoperative period. Next paragraph, certain risks must be considered with any surgery. Although every precaution be taken to avoid complications, absolute guarantees cannot be made. Clinical experience and judgment indicate that in general surgical risks are limited. However, surgery remains a human effort. Unforeseen circumstances can complicate any surgical procedure and lead to serious or even life-threatening situations. Although such complications are rare, you and your family should feel free to discuss the question of risk with the physicians. For any uncertainties patients may have, we encourage second opinions from other qualified neurosurgeons. I've discussed the above pertaining to lumbar spine surgery with my physician. He has explained the procedure and risk complications and indications to me in non-medical terms so that I understand them. He has explained my non-surgical options. I've been provided a copy of this form for my later review. Then it would say my diagnosis is, and there would be a specific what your diagnosis is, and I give my consent for Dr. Lederhouse to perform the following operation, and again, or myself or one of my colleagues, to perform the following operation, and then there would be a specific title on what your operation would entail. And we ask you to sign it and date it, and then if you do come in with a family member, then your family member or spouse or significant other would then witness your signature on this document as well. We give you a copy of this document so that you can keep. Your hospitalization time will depend on how long, what type of surgery you've had, whether it was a 1-level or a 2-level, or whether you've had screws put in on one side or the other. Generally speaking, the hospital stay can range from anywhere from 2 to 4 or 5 days. The time spent in the hospital depends on your pain response, or how much pain you're having, your ability to get in and out of bed, to be able to go to the restroom normally. So once you're up walking well, taking just oral analgesics and getting in and out of bed well, then you can go home. Again, that time spent in the hospital will vary from patient to patient. Now, while you're in the hospital, we use what's called a PCA pump, or patient-controlled analgesia. That's a machine that will deliver pain medication to you when you press a button. This is ultimately controlled by the nurses as far as how much medication will go in and how often. Of course, those are orders that are given to the nurse by the physician. So if the patient's not getting enough pain medication, then that can be changed. This is also ordinarily supplemented with oral medication for pain and maybe some anti-inflammatory medicines. The pain medications can produce constipation, and as a consequence, we will routinely give stool softeners during the time spent in the hospital. Constipation can add to back pain issues and postoperative pain, and so by being a little bit loose on the stool, then that will make it easier in your recovery. We will also have patients with a Foley catheter, which is a catheter that will drain urine, and that's left in place for 1 or 2 days. After a couple of days and the patients are more mobile, then the Foley catheter is removed. Again, on medications, if there's nausea, because pain medications can produce nausea, we can either switch the pain medications and we will routinely add an antiemetic, which is a medicine to help control nausea. That's a medication that you would need to ask for, since it's not routinely given on a regular basis unless the patients are nauseated, and the nurse wouldn't know you're nauseated unless you tell the nurse. So there is a medication that can be used to help with that. In addition, while you're hospitalized, we'll frequently have a cooling mattress put on the bed that will deliver cool circulating water. This is to help with the swelling after the operation, but also it can help and reduce the amount of pain medications that may be required. Patients are allowed to shower after the operation because oftentimes we'll use, as I mentioned, this Dermabond material that will seal in the wound. Even if there are sutures that need to be removed, oftentimes after a day or so, then patients can shower. We usually recommend that the patients try to keep the back as dry as possible, but can be in and out of the shower. Consequently, when you go home, no baths in the bathtub or swimming pools or jacuzzi until usually a couple of weeks or so after the operation, and you can discuss this with your physician. But when you first go home, then showering is permissible. A physical therapist will visit you, and they will assist you in standing and walking until you're independent. So you can use them for assistance in walking. They can train you on use of stairs if you have stairs in your home and becomes an issue. They will continue to follow you until they feel that you're independent, getting in and out of bed, at which time they would sign off of your care. So as mentioned, once you're up and ambulating, eating well, avoiding spontaneously, and taking oral analgesics, then that would be the time that you can consider going home. Operative office visits are usually within about 10 days after the operation. We inspect the wound, see how you're doing at that time, and then we'll provide exercises for you to perform. We would usually see you on a monthly basis. We may get periodic x-rays, although there's nothing written in stone as far as how many x-rays to obtain or how frequently. If there are any pain issues, or even if you'd just like to know how things are coming along, we can certainly order an x-ray, and that's not a problem. Again, we wouldn't see mature fusion for over a year or so, and so sometimes we'll have patients come back later on, even though they've been dismissed from the office, and obtain an x-ray just to see how the fusion process is coming along. But there are no hard and fast rules as far as how many x-rays to obtain over what time period. Hearing this written consent discussion, it's encouraged that you speak with your individual physician and ask any additional questions that you may have, and feel free to ask us whatever questions that may come to your mind, however silly it may seem to you. We just want that you feel comfortable with what decision you make, and we're here to provide you information. We're not here to tell you what to do in making the decision. The decision is ultimately up to you, and we like that all of our patients are as fully informed as possible, and that's the reason for doing these videos. So any additional questions that you might have, feel free to ask us. Your physician will also speak with you afterwards and beforehand, giving you specifics about your individual case. And so we're available. We want you to be informed. We don't want any mysteries about what's going on, and we feel that patients who are well informed also make good decisions. So that's the intent of why we're here with this discussion. So I hope this has been an informative video for you, and again, please feel free to ask us whatever questions may come to mind. Thank you.